Hi everyone, my name is Bero Yufenyu and I'll be doing a presentation on Effexor, also known as Venlafaxine. Effexor belongs to a drug class called serotonin norepinephrine reuptake inhibitor. It is FDA approved for major depressive disorder, generalized anxiety, cataplexy, social anxiety disorder. Off-label use include fibromyalgia, diabetic neuropathy, hot flashes, migraine, and PTSD. It works by boosting serotonin and norepinephrine throughout the brain and increases dopamine in the prefrontal cortex by blocking their reuptake at the presynaptic terminal. It is prescribed only to people 18 and older and should be taken with food. Avoid alcohol while taking medication as it can lead to increased sedation. It is available in both immediate release and extended release. The extended release is taken once a day and cannot be cut or crushed. Side effects of Effexor include nausea, insomnia, headache, hypertension, impotence, libido, constipation, weight loss, blurred vision, hypercholesteremia, tremor, serotonin syndrome, hyponatremia, nightmares, and blurred vision. It also has dangerous side effects, which include increased suicidality, fatal skin conditions such as Stevens-Johnson syndrome, toxic epidermal necrolysis, erythema multiforme, deterioration of glaucoma, angle closure, and seizures. It is contraindicated with use of monoamine oxidase inhibitors, seizure disorder, closed angle glaucoma, pregnancy, breastfeeding, worsening suicidal ideation, and psychosis. It can be associated with severe side effects when stopped abruptly. The first case study is about Mrs. O. She is a 58-year-old female with 5-year history of major depressive disorder. Her background is she lost her husband from a motor vehicle accident about 5 years ago, and she was with him while the accident occurred. This led to her developing depression and PTSD. Demographics: 58-year-old African American female. Chief complaints include feeling down, having low energy, difficulty falling and staying asleep, loss of interest in activities, and difficulty concentrating. She also complains of nerve pain in her extremities and hot flashes. History of presenting illness. She has past medical history of diabetes, depression, PTSD, and hypertension. So she has the complaints of low energy, difficulty falling asleep, feeling guilty, losing interest, and having difficulty concentrating. As mentioned above, she was involved in a motor vehicle accident which led to her developing of depression and PTSD. She was placed on Lexapro, but she stopped taking it because she felt like it's no longer working like it should. She also complains of nerve pains and described it as tingling sensations and pins in her hands, and she's also experiencing hot flashes due to menopause. She denies any suicidal or homicidal ideation, and these are her vital signs. Past psychiatric history is positive for depression and PTSD. Current medications include Lexapro, which she stopped, metformin, and amlodipine. She denies substance use, surgical history of hysterectomy. She's a widow. Family history: her mother has diabetes and her father has hypertension. No known allergies, drug allergies. Assets: she's knowledgeable about her illness. Liability: she stopped taking her medication without contacting provider. On her mental assessment, her PHQ-9 was 15, which qualifies her as moderate depression. PTSD screening was positive for trauma. ICD-10 diagnostic criteria include her symptoms, which were depressed mood, decreased energy, sleep disturbances, fatigue, loss of interest in activities that she loved, and isolation. So her diagnosis is persistent depressive disorder and PTSD, and differential diagnosis major depressive disorder. Medical diagnosis is diabetes, neuropathy, and hypertension. So her treatment plan will start her on Effexor at 37.5 milligrams daily, then go to 75 milligrams after a week and gradually increase to 150 milligrams if the 75 milligrams is not adequate. We'll do a lipid panel and CMP just to check for cholesterol and sodium levels since Effexor is associated with hyponatremia and hypercholesterolemia. Also, psychotherapy, specifically cognitive behavioral therapy, will be recommended, and family education will include to monitor for side effects and notify provider of worsening suicidal ideation. Patient will be notified to let provider know before she stops taking medication due to withdrawal symptoms, and she will be referred to therapies for counseling for both depression and PTSD. So discussion, Mrs. O has persistent depression. She's used SSR and was not effective. She has no risk factors or adverse reaction to Effexor. Effexor is appropriate since it's FDA approved for the treatment of depression, and it's also used off-label for neuropathy and hot flashes, which she's currently experiencing. Potential barriers may be the bothersome side effects, and since she already has history of stopping medication, it could lead to non-compliance. Cultural consideration is stigma to having depression and racial bias. Case study number 2 involves a 60-year-old male with diagnosis of major depressive disorder. He is a retired veteran who served on active duty for 8 years. He battled with alcohol abuse and depression due to his inability to have a job. Demographic: 60-year-old Caucasian male. He presents with symptoms of feeling down, extreme fatigue, decreased appetite, unworthiness, pain from knee replacement surgery, and difficulty concentrating. So this is the presenting illness, which we just mentioned all the symptoms. So he states he had a knee injury while serving in the military. After discharge, only God was, and he eventually had a total knee replacement surgery. Since then, he has struggled to do things for himself, and he relies on loved ones for everything. He also lost his job, and he's not just been feeling himself since after the surgery. Past medical history is hypertension and seizures. Surgical history: total knee replacement. He's currently on warfarin, metoprolol, dilantin, and tramadol. Social history: he's married, unemployed, lives with spouse, and has 2 living children. Family history: depression, substance abuse. He has history of alcohol abuse, and he denies any drug allergies. So based on his mental health assessment, his PHQ-9 score was 13, which qualifies him for moderate depression. His mental health assessment, the patient appeared to have a flat effect, was well dressed and withdrawn, giving him a score of 22. ICD-10 criteria used was his symptoms of feeling down, extreme fatigue, decreased appetite, unworthiness, and difficulty concentrating. Assets: he's clean appearing and demonstrates a level of self-care. Liability: he's withdrawn and non-participatory. Physical exam shows no acute findings. Diagnosis was major depressive disorder. Medical diagnosis: hypertension and seizure disorder. So the patient has major depressive disorder, but he is not a good candidate for Effexor, and is due to the following reasons. He has history of seizure disorder, which is contraindicated with Effexor. He has a history of alcohol abuse, which if combined with Effexor can result in sedation. Finally, he's on a beta blocker, and the effect may be reduced with concurrent use of Effexor. A combination of Effexor and tramadol can lead to life-threatening serotonin syndrome, which we don't want. So treatment recommendation for him will be referral to psychotherapy, and then another antidepressant like Ramiron will be better for him since it has minimal effect on seizures. He will also be referred to neurology for seizure management. So what I have learned: both patient encounters were unique. They had similar diagnoses but required different treatment approaches. The treatment approach provided to both patients were evidence-based. Completing a mini mental exam is helpful because the provider can pick up signs and symptoms which were not expressed by the patient. A comprehensive physical and mental exam is also advantageous to both patient and provider because it allows for building of rapport and effective communication. The use of lab testing was essential for medical conditions as hypercholesterolemia and hyponatremia, which could be worsened with Effexor. The patient received educational materials that included information on diagnosis, side effect, administration, interaction, and contraindication, and all their questions were addressed. The importance of follow-up appointments and referrals were emphasized, and both patients verbalized understanding. My takeaway: following my interactions with both patients, it's observed that major life events can make people more susceptible to depression. It is equally essential to ask patients about their past medical and family histories because this helps identify risk factors and guide treatment plans. It is essential to always inquire about the patient's current medications, including prescriptions over the counter and herbal remedies. Cultural considerations are also important when considering medications to be prescribed. Well, thank you for listening, and these are my references.